So I started off asking this question that William started about cancer and biologics. And so I can kind of fast forward this. I think that this is the shared and informed decision-making process that we go through. And I think it's quite clear right now what the outer boundaries of cancer and biologics are. And I had thrown in this meta-analysis by Xavier Mariette from 2011, which quite clearly looked at the influence of exposure of anti-TNF versus no anti-TNF in an RA population. And you can see from this tree plot here that, the overall risk of malignancy is really not any different from TNF treated to a DMARD comparison control group. Quite obvious. It crosses unity. Non-melanoma skin cancer, everybody knows this, and we've got some granular data on this that William showed. Yes, there's an increased risk of rheumatoid versus non-rheumatoid, and there is an increased risk of being on a TNF inhibitor versus being on a DMARD comparator. I'll get a little more granular on that. The issue of melanoma has been kind of like an elephant in the room. This is a rare tumor, but it's a bad tumor. And as you can see, based upon, in 2011, the confidence interval, really did not totally move to the right of unity, but there's a strong suggestion that it was there. So, what did we learn? I picked out the same type of study just to point out this again, TNF exposed versus biologic naive group. Where we really saw it was that the risks were for the first squamous cell. It was not very impressive for invasive, mostly for in situ. So it kind of furthered our beliefs on this. There was really no risk of basal cell carcinoma, really mostly non-melanoma, in situ skin cancer, something that's easily monitored. And I'm really interested to hear from you out here in the sun country of what you do in terms of your best practices. How do you screen people? I mean, we don't worry about it that much back in Cleveland. So he also picked out the melanoma. This meta-analysis for melanoma quite clearly, based upon now moving fast forwarding from 2011 up till now, showed that there is really no statistical epidemiologic risk for melanoma, yet considering the gravity and the morbidity and mortality of melanoma, we look at it a little differently. So I picked out a paper, even though when you do shared and informed decision-making with patients for biologics, you can say there's no increased incidence of tumors of any sort over and above a comparative group of people on non-biologics, except for in situ squamous cell carcinoma, and we can have a strategy to monitor for that. We do worry about melanoma. If you had a personal history of melanoma, there is something that generates concern, but not to the level of statistically significant. But I found this paper just last month or so, which gives us a small amount of pause, and it was just anecdotes, and dramatic anecdotes always kind of come to the top. And this was 3 cases of uveal melanoma in patients who were TNF exposed, 1 RA, 2 IBDs. These are patients, several of them that had scleritis. The scleritis seemed to subside, but there was still a residual thickening in the uveal tract. The ophthalmologist led to be suspicion ultimately biopsy and enucleation for these 3 patients. So they actually raised the question of, this is such a rare occurrence to have 3 of them in TNF-exposed patients. Just gives one pause for practice patterns. So I'm going to leave you with this kind of rhetorical question. All right, so I'm going to switch gears. So this caught my interest. So this is St. John's, and this is a pretty cool place this time of year. And this is a mosquito, and that is the Asian tiger mosquito. And everybody should now know, you're good test takers of what I'm going to talk about, and it's caught my interest at the meeting and it's had my interest for a while. So the subject is alpha virus, and these are Arboviridae. There are over 30 members of this family of viruses. They're divided into Old World, New World. They're unique because of their arthritogenicity, unlike any other family of viruses. In other words, that these viruses do cause arthritis when exposed. The disease is chikungunya, and up until 2012, this was the epidemiologic map. So chikungunya is an alpha virus, Arboviridae, that was first described in the 1960s in sub-Saharan Africa with an epidemiologic focus in what was Mozambique. It stayed isolated to Africa. It would erupt, it would regress, and was really not on anyone's radar screen until about 2009, 2010, when it migrated from Africa to the Indian Ocean. And it became prevalent in islands that were used as vacations for Westerners, including Mauritius and the Seychelles. It didn't take too long for it to make the leap to the western Indian coast, and within a couple of years there were several million patients with chikungunya in the Asian basin. So this was kind of interesting to me. I was writing an editorial for The Lancet on viruses and rheumatic disease. And at that time, in 2008, when I wrote this, and I live in Cleveland, Ohio. We don't see these, but because of my interest in this, making some commentary on it. So it was already quite obvious that patients who were vacationing in these areas in the Indian Ocean, particularly from Europe, they would come back and they would have this disease, which I'll describe to you in a minute. And you probably all read about it in the New York Times and other articles. And so this disease had been seen in Europe, largely in travelers. Well, this disease is transmitted like dengue, which means that it doesn't require an animal intermediate. All you need is an infected person, a mosquito, and an uninfected person. And if you're in the wrong, spatial array here, you get this virus from that person. Doesn't have to go live in a bird or a monkey or anything else. So it is a disease that can be spread in urban areas like dengue. The factor that had kept it bottled up to these tropical areas was that the primary mosquito was Aedes aegypti, the primary vector for dengue. And that is not highly prevalent in the United States, although you do have it in Arizona. In 2007, 2008, there was a mutation in the chikungunya virus, which allowed it to be carried by another mosquito called Aedes albopictus. Aedes albopictus is a very common mosquito in the southern tiers of the United States, certainly well within Arizona and Florida and the Gulf Coast. So it raised the issue. It said, well, geez, all you needed is if you come back from this area and you're sick with chikungunya and you have literally millions of particles in your blood. I said, what if? I said, if you ran into the right mosquito, you could have a local endemic spread of this. And I said this out of like total naivete of somebody who doesn't know anything about Arboviridae in the least. And by the time my editorial had been reviewed, it was obviously reviewed by somebody who understood mosquito-borne illnesses, there was a local regional outbreak in northern Italy, in Ravenna, that occurred from a man who had traveled to India, came back, and there were over 200 cases of chikungunya in Ravenna in the end of September of that year. And the Italians took very seriously, and they wiped out all the mosquitoes in this area, and then it became fall, and it ended. So it was quite clear that this could spread. And then the story changed in 2012. Up until 2012, there had been no local regional transmission of chikungunya in the Western Hemisphere. None, zero. A lot of patients, about 1,000 patients had got chikungunya and had come back to the United States, but it had never transmitted to another person. It was recognized. It is a bad disease. I'll describe it in a second. But the story got very, very interesting in and around that time. It started as a kind of a point source epidemic in St. John's, and now 25% of that island has been infected with this. So I've had this conversation with so many people going to the Caribbean, and I've freaked out a few people with this. Now there have been over 1 million cases in the Western Hemisphere. So this is not like, Ebola or something. First of all, it's a totally different disease, but it is not a rare disease at all. And in these areas, this is a very, very, very significant. Now, just to show you that it's really a disease. So my nurse practitioner sent me this. So Lindsay's been tweeting that she's apparently getting over chikungunya, but I'm not totally sure of this. So what does this disease look like? The disease is quite profound. It has an incubation period of somewhere between 3 and 10 days, usually about a week. It starts with this intense febrile and musculoskeletal phase. And the word chikungunya is from some Makonde dialect, which means to bend up or to break, because the early phase of this, the acute phase, is profound, and it is not something that you want to get. That acute phase may last from a period of days to a few weeks, and I'll show you a picture at the end of what this actually looks like. And then it has a subsiding phase, and that subsiding phase may last from weeks to months. There are small numbers of cases that have been described to last for far longer than that, but other Arboviridae like that have been really well studied, like Ross River in Australia, suggest that it's kind of like a post-Lyme thing, and there's probably pain amplification. But it is something that can lay you up and be disabling for several weeks to many weeks once it is once you get it. So there were several abstracts at ACR on this. One was just looking at immunophenotyping of these patients and actually comparing them to a group of seropositive RA patients. And they did this kind of spatial analysis, a cluster analysis of varying immune activation markers. And basically, this showed that a patient with acute chikungunya looks like a patient with active and untreated rheumatoid arthritis from a 30,000-foot view of looking at T-cell activation markers and acute phase reactants. So it is an immunologically driven disease that is poorly understood, but it's easy to see why these patients have such active and significant disease. The second abstract I thought was interesting because it said, well, what if you have rheumatoid arthritis and you're in these areas and you get chikungunya? If 1 out of 4 people on St. Martin's get chikungunya in general, that should mean that 1 out of 4 rheumatoids have got it. So they actually collected a group of people, 22 rheumatoids had chikungunya. They were on all of these. The focus of this was to look on biologically treated patients. So there was a lot of background non-biologics, including 2 people on cyclophosphamide. Half of this group was on glucocorticoids. And they did a control population of chikungunya who didn't have this, and it did not lead to any worse disease in the rheumatoids than in the non-rheumatoids. So an observational trial, but at least providing a little scant bin of clinical data about this. So there's no enhanced morbidity in this. Now, one of the more interesting in the question here is, what is the natural history of chikungunya? So it looks like rheumatoid arthritis. It is often additive, wrists, MCPs, ankles, MTPs, can involve large joints as well, particularly during the early phase. So of these 14 patients that were followed at least 12 months, with no history of pre-existing pain syndromes, 8 of the 14 lasted at least 6 weeks post-infection. 7 of the 14 had this persistent arthralgic, and 2 they described as developing a chronic arthritis. So a very small but well-studied group. The arthralgia was symmetric and polyarticular in all cases. Ankles was the most commonly affected joint in this group. So their conclusion was that this was severe, debilitating arthralgia, affecting quality of life, could last as long as a year. Certainly nothing that you would want to have, and risk factor analysis is underway. So this is what the disease looks like if you're just interested in it. And you're seeing patients who are traveling. In Florida, there have already been pockets of endogenously transmitted chikungunya in 2 counties. That means that a person has come from the Caribbean, has been in Florida, got bit by a local mosquito, and has infected other local people. Since you have both Aedes aegypti and albopictus in Arizona, this is clearly potentially a possibility. As you can see, immediately following the mosquito bite, there's this intense viremia that occurs. Within a period of a week or 2, you start to see an initial antibody response. It's IgM, then transitioning to IgG. There is a T-cell response generating memory T-cells. But if you're seeing a patient within the first 2 weeks, there are 2 studies that are of value. IgM, anti-chikungunya, which is sent to local referent labs. CDC and state health departments are all doing this. And if it's really early, a chikungunya viral load, which will last during this incubation period. But the diagnostic test of choice is IgM, chikungunya antibodies. The IgG stay positive for a long time after that. So there have been many recent articles here. I'm hoping that these studies may influence the way you think about these patients, particularly in this area. And if any of you get any subsequent cases of chikungunya, I would really, really appreciate an email to let me know what's going on. So the last thing I want to talk about is Zoster. I thought this was very interesting. You know the background of it. We talk about it because our patients are at increased risk for Zoster. It's been quite well demonstrated. Why do we need a strategy to prevent shingles? Well, it's a morbid disease. Secondly, shingles has its own complications, and we are just getting a whiff that there is a major complication that we should be aware of, and that is the risk of shingles and stroke. I will just summarize that there are 4 robust epidemiologic studies published since 2013 that have demonstrated that simply having shingles, dermatomal zoster, regardless of its anatomic distribution, places one at risk for stroke over a period of a year. Now, these 4 studies, including this most recent study in CID, all show that the risk for stroke is strongest early on, particularly in the first 3 months, then to 6 months, and then 6 to 12 months, and then dissipates. Secondly, it's demonstrated that most of these studies agree that if you have herpes zoster ophthalmicus, you're at greater risk for stroke than all visceral shingles. And then thirdly, prompt, early, and aggressive antiviral therapy may decrease the rate of stroke. So the point that I'm making is shingles is a bad disease. No, we don't want to, we don't like it when our patients have it. There are reasons over and above just the ignominious pain and post-herpetic neuralgia that we usually think of wanting to prevent shingles. And this is now the latest story in shingles morbidity. So having said that, you all know that there is a vaccine. This is our little part of the ACIP CDC guidelines, and that Zostavax is a highly effective vaccine, decreases the rate of shingles by 50%, decreases post-herpetic neuralgia by 2/3. We don't know. I've given you all the data I can about stroke. So there the issue here is that we have guidelines to treat, but we know that people on biologics are proscribed. It is written as a contraindication to Zostavax. What kind of strategies do we need? I'm going to skip through the epi. Steve Lindsay did just a really nice study. So Steve's a smart guy. He's been paying attention to the Zoster literature. He's a very busy rheumatologist like you guys. And he said, I saw Jeff Curtis's epidemiologic study that suggested that shingles vaccine works in people even if they're on biologics. It looks like it was fairly safe. You tell me that the recommendations to avoid shingles vaccine is based merely on expert opinion, so I think I'm going to try it. And here's how he did it. So he first looked at the indications for Zoster vaccine, recommended for patients over the age of 60, but approved for people over the age of 50. He went into his practice. He had 302 patients with RA, PSA, or AS who were on a biologic. Of these, he selected those people that were above age 50, had no other contraindications to Zostavax, who had not had a recent episode of shingles in the past 4 years. And he said, here's how I'm going to do it. I am going to give this vaccine at the next interval of scheduled biologic. So in other words, if you were on Enbrel, you would stop the Enbrel, and then at the time when you would be getting your Enbrel dose the next time, so he would give you the Zostavax and hold the next dose of biologic for 2 weeks and held methotrexate for 1 week. How did you come up with that? It's just the way he wanted to do it. And the primary safety endpoint of this was exactly the same safety endpoint in the pivotal vaccine trial for Zostavax, was that did anybody get shingles within 42 days of vaccination? And the answer was 0 out of his entire group. So his approach to this appeared, in not an insignificant number of patients. There was no adverse events, no disseminated shingles, no shingles of any sort. And so this gives us a little impetus to move this question along. There is a trial that is just being launched called the VERVE trial, PI'd by Jeff Curtis, that is a primary safety endpoint trial of patients on TNF inhibitor therapy that will be given concomitant Zostavax. This won't be done for another 18 to 24 months, but people are looking at it. And then the last thing I'm going to throw out here is a follow-up. It's very similar to what Elaine was talking about. I asked the question of, so vaccinations. We could have the same question for the cardiovascular risk reduction that Elaine showed, asking for vaccination. What's our job in vaccinating patients? What's our job in doing cardiovascular risk reduction? So, it's another thing, and it's complicated. But I will tell you, if you think it's complicated for a primary care physician to figure out what cardiovascular risk reduction to do, it is far more complicated for them to see a patient on Orencia or, Actemra or Humira and say, like, what am I supposed to vaccinate this person with? They run for the hills for this, at least in my experience. So there were a handful of abstracts, a large handful, that used varying system-based strategies, whether it be EMR, soft or hard stop, asking a patient survey regarding barriers to vaccine, just asking the patients to cue you, saying, what can you tell me about my vaccines? All of these work to increase vaccination rates. So I would love to hear anybody has a best practice here about what you're doing to vaccinate patients in your own practice, because I don't think that we're doing as good a job of this as we could potentially do. And I don't have a simple answer for this, and I don't think that we at the Cleveland Clinic are doing a very good job of it, but we're looking for some way to change our system to do this. So, no, there's no antiviral therapy of any benefit right now. There's rapid development of a vaccine, now that it's moving into the Western Hemisphere, moving ahead. And it's interesting. There are the anecdotal stuff that people that have developed a more chronic version of this, so it doesn't go away in 6 weeks, and still, which is not uncommon. People have been using hydroxychloroquine. It is quite clear that glucocorticoids will shut this off temporarily, but there's great fear, and they don't really know its effect on viral load and stuff like that. But I actually think that based upon what we know about the cytokine profile, that there probably could be a low-dose approach, but I've never done it and not advocating it. Well, that's interesting. So what does the pharmacy do? So Jeff Curtis, he did his own beta test, and he went into like 3 CVS and a Walgreens, and he got the forms and went through the thing, and in none of those was he precluded when he says, I have rheumatoid arthritis. They said, well, that's okay. Anyway, so I think there's a quality control issue here, and we're in the process of designing a study to answer the question: Does zoster in rheumatoids lead to stroke like it does in non-rheumatoids? Since rheumatoid patients get more zoster, if the answer to that is yes, I think that there will be a compelling public health reason to want to do this. At the moment, I think that the greatest opportunity for doing this the easy way is before a patient goes on to biologics. Certainly if they're 50 years of age or older, I recommend it. And regardless of, I lay this out in shared and informed decision making, whether they get coverage or not, I'll recommend it and let them engage in whether they want it. You're asking a different question below 50, but I think that the data is growing. So I'm going to stop right now. We're at our break. We'll take a little break, then we'll come back and close up on this. So anybody else has a question or comment, talk to you out there. Thank you.